So just 1 minute and we'll start. Just 1 minute and we'll start. Okay, so can I get thumbs up if you can hear me and see me? Or anything in the chat, just to ensure that the technology is working. Great, thanks, Patrick. Generally speaking, if there is a chance for you to keep your cameras on, that will help a lot because it's just going to give me the feeling that I'm not talking to my screen. So that would be really great. Thank you so much. Okay, so uh, my name is Hisham. I'm one of the ED consultants in UK, and it's a pleasure to be with you here today. Some lovely, friendly faces. So, without any further ado, let me share my screen with you so we can start this session. So, you should be able to see my screen as a full screen now, I hope. We good? Okay, let's make a start. So in the next hour or so, we're going to be talking about syncope, which is a really important presentation that I really like talking about, uh, because syncope by definition means that your patient is back to normal, and that on its own is really concerning because there is a good chance that you might send these people home and they might have a life-threatening condition. So this is what we are going to be talking about, and let's jump into our story. So this is a patient that was a 19-year-old male presented to ED with recurrent episodes of palpitations and pre-syncopal event. So this patient didn't really faint, but was about to faint, felt that they're about to faint. There was no chest pain at all. There was no breathlessness at any point of time. A 12-lead ECG was done on arrival to ED to find this. And that was quite scary to see. And I really hope that you are all unhappy to see this because you should be. Because this is, as you can see here, a broad complex regular tachycardia. That means we're dealing with a ventricular tachycardia until proven otherwise. So, the patient was immediately transferred to the resus room. On arrival, his heart rate changed. So another ECG was done, and this was his baseline ECG that was done in resus after the spontaneous resolution of his ventricular tachycardia episode. So I'll give you a few seconds to look at this before I ask you that question. Feel free to scan this QR code with your mobile phones and be honest with your answer. Based upon the ECG that you're looking at now, can you tell what the reason was for the VT? Your answers will be anonymized, so feel free to pick whatever you want. No one will know. So scan the QR code, pick one of the two answers. Do you think, looking at this ECG, that you can tell the reason for the faint? Okay, we've got some answers. Let's see. Okay, thank you. That is really good because it means that I've got something to do, and I might be useful for you in the next 45 minutes. Great. Let's talk about this then. Probably this slide is the most important slide in the whole presentation because this slide will summarize all the differential diagnosis that I think about when I see an ECG of a patient with pre-syncope or syncope or intermittent palpitations. When I see an ECG of any of these three presentations, this is the differential diagnosis that I go through before I put my name and registration number on this ECG paper that it is okay for this patient either to go home or to wait to be seen. Top three are what I would call the no-brainers. You're not going to miss those. You're going to pick them up, and I'm not worried about you missing them. Acute coronary syndrome can cause intermittent ventricular tachycardia that can make you faint. So if any signs of STEMI or myocardial ischemia in DCG, that would explain why the patient fainted. Any sort of arrhythmias and heart blocks would explain the syncope. And pulmonary embolism can cause ECG changes and can make you faint. So far, those are the top three no-brainers that I am not worried about you missing. What I'm worried about you missing are the next few. We've got two abnormal intervals that you need to be aware of, the PR interval and the QT interval. Both can be long, both can be short, and the four conditions are bad and can make you faint. When we talk about the PR interval, they can be short in pre-excitation syndromes like WPW, and this can make you faint. And they can be long as a first degree heart block. On its own, you're not going to faint because of this, but if you have first degree heart block plus axis deviation plus right bundle branch block, this is a trifascicular block, and in presence of syncope, that might be an indication for a pacemaker insertion. So looking at the PR interval, whether it is short or long, can give you clues regarding the reason for the faint. QT interval, same thing. Long QT we're familiar with and we're hopefully not going to miss. And you know that it can cause badness. Short QT is less commonly talked about. It's less common to see, but it is a possibility, and it's as bad as long QT in terms of causing problems that can make you faint. So these are the two abnormal intervals that you'll need to look at in these three different presentations. And then lastly, we've got three congenital problems here to think of: hypertrophic cardiomyopathy, Brugada syndrome, and arrhythmogenic right ventricular dysplasia. The three congenital conditions are all autosomal dominant. They can all make you faint or present with a sudden cardiac arrest, and they are all dangerous to miss and important to be aware of. And that will be the clue for our today's case. So let's go back to the ECG that we've just seen together, and let's try to analyze it to find out what's going on. So the first abnormality that you would notice in this ECG is that we've got T-wave inversions in V1, V2, V3. It is normal to see an inverted T in V1, but not in V2 and V3. That is a bit too much. And the other thing to notice here that it is not just a T-wave inversion. The T-wave inversion can present in two different shapes. The T-wave can be inverted and asymmetrical, like in here, and they can be inverted and symmetrical, like in here. So symmetrical and asymmetrical. Those ones that we're looking at now are all symmetrically inverted. On its own, that is a red flag. The two types of the two shapes of the T-wave inversions are abnormal, but the asymmetrically inverted one can happen with, let's say, more of a benign conditions. That can be just because of left ventricular hypertrophy. This can be just because of maybe a bit of a strain pattern with high blood pressure. Abnormal, but not scary abnormal. The symmetrically inverted T's are always bad. When you see an inverted T wave that is symmetrical, be scared. This could be ischemia. This could be PE. This could be raised intracranial pressure. There is something bad about that symmetrically inverted T wave, and that is something that you shouldn't miss. This was the first abnormality that we can see here. The second one is this funny wave. After the T, after the complex, before the T wave. Over the over the ST segment here, there is a blip, there is a funny wave, there is something that looks a bit odd that is happening there, and that is in V2 there. This is called the epsilon wave. If you combine the two together, you will get the answer. We're dealing with a case of ARVC or ARVD. So this is the arrhythmogenic right ventricular cardiomyopathy or arrhythmogenic right ventricular dysplasia. So let's talk about this. So ARVC is named as arrhythmogenic right ventricular cardiomyopathy. Sometimes it's called ARVD as arrhythmogenic right ventricular dysplasia. Both are same thing. Basically, it's the second most common cause of sudden cardiac death in young people after hookah in many countries. It is way more common than what you might think. The problem is we miss the diagnosis, and that's why we think it is not that common. So it can cause up to 10% of sudden cardiac death for those below the age of 65. The incidence is 1 in 5,000, so it's not as uncommon as you might think, and it's particularly common in Italy and Greece for some reason. It looks like that the genetics there are playing a role, but in the population of Italy and Greek, it is a well-known condition. So the inheritance, as I said before, is autosomal dominant, and the male to female ratio is more towards boys, so it's a 3-to-1 in terms of the incidence. And here's what happens. This is the pathology of the condition. There is a fibrofatty replacement of the myocardium of the right ventricle. So a specific spot in the right ventricle, the muscle layer there will change and will be infiltrated by fibrofatty tissue. And this particular focus will act as a nucleus that will keep producing random arrhythmias because of the disruption of the transmission of the electricity around this particular point. So because of this fibrofatty change, there will be paroxysmal ventricular arrhythmias that will be coming from the right ventricle because this is where the pathology is. And this is an important point that we're going to come back to in a few minutes. In terms of the investigations for ARVC, ECG is what will bring it to the surface. That's usually the first presentation that you will, the first investigation that you will do for any syncope patient, and this is how we discover them. And echo might help. It might show a dilated hypokinetic right ventricle. Cardiac MRI is kind of the gold standard for diagnosis. I'm saying kind of because the gold standard, what's going to give you the answer, is the myocardial biopsy, but probably that would be a post-mortem thing, and probably if we're going to go down that route, it will be a bit late. So cardiac MRI is probably the way to go if you want to diagnose ARVC. And when it comes to treatment, these patients, if they don't have high-risk features, they are usually on a class 3 antiarrhythmic. So usually amiodarone or sotalol. Sotalol is usually the go-to drug for those ones. With high-risk features, they get an ICD. And if they are persistently symptomatic, sometimes the electrophysiology consultant would want to do a radiofrequency ablation. And if severe case, they go for a cardiac transplantation. You need to be aware of the possibility of the turbulence of the blood flow in the right ventricle because of the change in the myocardium there. So there is a chance for clot formation. So you need to consider anticoagulation for these patients, just like AF patients, for example. So this is in terms of treatment of these patients. So let's focus now on why we're here today. Let's focus on the ECG changes that happens with ARVC. You should expect to see T-wave inversion in the right precordial leads. This is, to be honest, the commonest finding that you will see with it. It is not specific. It is probably more sensitive than specific. And the T-wave inversion, as we said, will be most probably symmetrically inverted T-waves, and it will be in V1 to V3. Sometimes it can extend to V4. You will also see an epsilon wave in V1 to V3. You might see what they describe as localized QRS widening in V1 to V3 with a prolongation of the S wave upstroke. and we will come to this in a minute. You might see ventricular ectopy with a left bundle branch block morphology. And lastly, you might see paroxysmal VTs, just like what we've seen with the patient that we've just seen together. Here's the epsilon wave. So again, a blip, a funny wave, something that doesn't look right, just at the end of the complex, before the beginning of the T wave, somewhere on the ST segment. When you see this, that's an epsilon wave. This is the most specific finding to diagnose ARVC. It is seen in about 30% of cases of ARVC. And you've got the T-wave invergence. And as we said, the T-wave inversion will be symmetrically inverted, usually V1 to V3, can extend to V4, and you will find it in about 85% of patients with ARVC. So probably this is the commonest finding that you will see. You will see way more T-wave invergence compared to epsilon waves with ARVC patients. And an important bit here is you need to see this in absence of right bundle branch block morphology, because right bundle branch block on its own can cause the T-wave inversion in V1 to V3. And this is what they talk about when they talk about the S wave with localized swelling. So let me explain that to you. So if you look at V1 to V3, you will notice that we've got the complex and the S wave is going to be going down. So this is the beginning of the S wave, and then it will be like it's going up and then it will change the direction. I'm just exaggerating things here, going sideways to make the complex quite narrow at the tip of it, like in here, but quite broad when it comes to the upper part of it. So this is the localized widening, the widening that happened over there in V1 to V3, because the S wave to go back up, it takes longer time. So that is the prolonged S wave upstroke. The upstroke component is just deviated to the side, so it's taking longer time to go there. A very subtle sign that I wouldn't really expect that we're going to all spot it easily, but it's documented as one of the diagnostic features for ARVC. In my head, T-wave inversion is what I'm looking at, plus or minus epsilon waves. This is just an added feature. If you can see it, happy days. If not, this is what it is. So this was one of my patients that I've looked after about 12 years ago now. And this patient was known to have ARVC, presented to me in VT. He was in and out of ventricular tachycardia. He was known to have ARVC, and he's had an ICD in place. But when he presented to me, I think his ventricular tachycardia rate was around 160, 170, and his ICD was, the settings was to fire when the rate crosses 180. So when I saw the patient, he was in VT, but the ICD didn't work because the rate was below the threshold level for the ICD to fire. And I'm showing you this ECG because it doesn't show almost nothing of the features of ARVC, and this is a known patient of ARVC, and actually the son of this patient was screened for ARVC and he was positive. All what I would say in this ECG is there is a T-wave inversion in V3 and V4, and to be honest, there is a right bundle branch block morphology here, so I wouldn't even trust whether the T-wave inversion is because of the right bundle branch block or because of an ARVC. So this is a known patient for ARVC who's got a no ARVC ECG. So I thought I'll put that there just to show you a different example. This is from Life in the Fast Lane, and it shows all features of ARVC. We've got the T-wave inversions in V1 to V3, and we've got a beautiful looking epsilon wave, so a blip-like over there at the end of the complex before the T-wave over the ST segment. So you've got 2 out of 3. I wouldn't really see, I'm not going to say that I can see clearly the slurred upstroke of the ST segment of the S wave. So I wouldn't call this. We've got 2 out of 3 the features here. This is a known ARVC patient. So let's talk about Fontaine leads, because this is something, again, that people don't talk about it that much, and it's a very helpful thing to have in your arsenal at the back of your head if you're stuck with a query ARVC patient. So let's say that you've seen a patient who's coming to you with syncope. The ECG is not that conclusive. You're not really sure, is this just a movement artifact or there is an epsilon wave over there, Fontaine leads would help you with that. You'll need to change the lead position. So the right arm lead, you're going to put it at this point. The left arm, you're going to put it at that point. The left leg, you're going to put it here. The rest of the leads will be where they are normally. When you change the lead positions to these positions, that is going to increase your sensitivity of detecting the epsilon waves. It increases it to up to 50%. But the epsilon wave that you are expecting to see normally in V1 to V3, you will see them in the inferior leads, so 2, 3 AVF. These are the right ventricular facing leads, and when you change the position of your leads to put them that way, you will see the epsilon waves there. 2, 3 AVF, there will be more prominent epsilon wave compared to before Fontaine leads. So you've got your normal placement for leads, that is going to show you the epsilon waves in V1 to 3, and you've got the Fontaine leads position. Your nurses will ask you where to put the leads. Just Google it and show them a diagram that is this one or a similar one, and then they're gonna put the leads in that position. Rest of ECG will be fine, and that is going to show you the epsilon wave in the inferior leads. Let's talk about some interesting, important basic ECGs here. So let's imagine that this is our heart. We've got 4 chambers here. You've got your SA node, you've got your AV node, bundle of His, right and left bundle branches. What happens normally is the SA node is going to be the firing focus, the pacemaker that will stimulate the atria, and then the impulse is going to reach the AV node, and then it's going to cross it to the bundle of His, and then you've got your left bundle branch, and you've got your right bundle branch. I hope that we all agree with this. Next, let's imagine that you have got left bundle branch block. That means that your left bundle is gone. It's blocked. There is no transmission of impulse down this path. What will happen is the impulse will try to go left side and it will fail to go through. It will go right side and it will go easily. Stimulation of the right ventricle will happen first, and then the left ventricle will be stimulated after that. So in presence of left bundle branch block, your right ventricle is stimulated first, then your left ventricle will be stimulated after that. And we all know that in left bundle branch block, what you see in the ECG in V1 is this pattern: small r, deep, broad S. So again, with left bundle branch block, the right ventricle will be stimulated first, and then the left ventricle will be stimulated. And the outcome of stimulating the right ventricle first is this shape in V1. I hope we're happy with that. Then let's move on to the other side. In presence of right bundle branch block, the impulse will, so the blockage is going to be here on the right side, and it's exactly same way. The impulse will go to the left side to stimulate it first. So the left ventricle will be stimulated before the right, and then the right ventricle will be stimulated after that. So the impulse will go from here to there. And the outcome of this is, if you look at V1, you will see either this as a right bundle branch block morphology, or maybe this, or maybe this, or RSR dash, whatever. So all sorts of shapes for right bundle branch block, you see them because the left ventricle is stimulated first. So the key component to understand here is, with left bundle branch block, the right ventricle is stimulated first. With right bundle branch block, the left ventricle is stimulated first. So let's reinforce this. Fact number 1, with any left bundle branch block, the right ventricle is stimulated first because the left bundle is blocked. And the result of this is you'll see that shape in V1. Happy? Good. Fact number 2, with any right bundle branch block, the left ventricle is stimulated first because the right side is blocked. With right bundle branch block, the left ventricle is stimulated first, and because the right is blocked, and you will see the shape on V1. So when you stimulate the left ventricle first, you see that shape in V1. Why do we need to do this? Because there are so many important applications that you would benefit if you see, if you understand this and you apply this to this. So let's have a look at some clinical applications to these facts. When you have a patient who's coming to you with a PVC, so premature ventricular complex in the ECG, if the PVC is coming with a right bundle branch block morphology, you can tell that the focus of this PVC is in the left ventricle, because we all know now that right bundle branch block morphology means that the left ventricle is stimulated first. So you can tell where the focus is by looking at the shape of the focus. If it looks like right bundle branch block morphology, that means that the focus is in the left ventricle, because it's going to stimulate the left ventricle and then propagate to the right side. So that's the first fact, and vice versa. Second, with pre-excitation syndrome with WPW, you will have an accessory pathway to either the right side or to the left side. You can tell where the accessory pathway is it right side or left sided, by looking at the ECG. So that is the two types of WPW, type A and type B. Type A will have a right bundle branch block morphology, which means that the pathway, the accessory pathway, is on the right side, because it's in the left side, because it's stimulating the left ventricle before the right, and vice versa. And lastly, and this is the most important bit that is related to what we're talking about today, when you have a firing focus of VT in the right ventricle, that means that you are stimulating the right ventricle first. That means that you'll have a left bundle branch block morphology in your ventricular tachycardia. So let me show you some examples. That is a broad complex regular tachycardia ECG. This is VT. Look at V1. It looks like we've got right bundle branch block morphology here. That means automatically that the firing focus is in the right ventricle. And we all know now that if the firing focus is in the right ventricle will be stimulated first, and it will look like this. So this is a, left ventricle. So this is basically right bundle branch block morphology. That means that your firing focus is in the left ventricle, because the left ventricle will be stimulated first to give you that pattern, and you can tell where the firing focus is. While in here, that is a VT with a left bundle branch block morphology. That means that the firing focus is in the right ventricle, and this is what happens with ARVC. So ARVC, the pathology is in the right ventricle. That means that if there is a VT, it will be coming from the right ventricle. That means that this VT will be causing a left bundle branch block morphology in the ECG. And now we understand why that happened. And that's one of the differentiating features here. If you see VT that looks like right bundle, like this one, less likely that this is because of an ARVC. If you see a VT that looks like this with a left bundle branch block morphology, more likely that this is because of ARVC. So let's go back to our patient so we can summarize what we've talked about. This was a 19-year-old male that presented to ED with recurrent episodes of palpitations with pre-syncope. This patient had no chest pain or breathlessness, but was in and out of VT of left bundle branch block morphology, so it was coming from a focus in the right ventricle. He was known to have ARVC, and to be honest with you, his VTs were self-terminating, so that made our life easier. He was referred to the inpatient cardiology team, and he was admitted for further treatment that was including a plan for an ICD insertion. So a quick summary here. When it comes to syncope in ECG, don't forget the three no-brainers: ACS, arrhythmias, and PE. Don't forget your two intervals, PR interval and QT interval. For both, long is important, short is important. And don't forget your three congenital problems that are all autosomal dominant in inheritance, and all are way more common than what you might think: HOCM or hypertrophic cardiomyopathy, Brugada syndrome, and arrhythmogenic right ventricular cardiomyopathy. When it comes to ARVC or ARVD, that's the second most common cause of sudden cardiac death in young people following HOCM. It's a fibrofatty infiltration to the right ventricular myocardium, And to be honest with you, it's been reported to happen in the left side as well. So I'm not sure if that name is going to stay or not. But there are case reports about ARVC with the pathology in the left ventricle. But that is not the common presentation of it. And the outcome of having the focus, the abnormality, the fibrofatty tissue in the right ventricle is a left bundle branch block morphology PVCs and left bundle branch block morphology ventricular tachycardias. They present with VT and they can present with a sudden cardiac death. And lastly, to diagnose from the ECG, you'll find the T-wave inversions. That is the more common finding. In V1 to V3, there will be inverted, there will be symmetrical. And also you'll see the epsilon wave, small blip, small notch at the end of the complex in V1 to V3. If you want to make the epsilon wave more prominent, use the Fontaine leads, and that's going to help you to see what you cannot see without them. But when you use Fontaine leads, look at them, look at the epsilon waves in the inferior leads, so 2, 3, AVF. And this is pretty much it about the ARVC. So this is it regarding what I wanted to cover with you guys. And now is the time for your questions. So I'm going to stop sharing my screens and let's have a chat in the next, we've got about half an hour of a chat if you want to. Any questions, either you can talk or you can put it in the chat section and I will check it from there. Any questions?
Can you please show the two last slides again, which
Yeah.
was showing because it went a bit fast to kind of,
No, that's fine.
thank you.
Let me share again my slides. Okay, do you want the summary slides?
And the one which showed the pathology with the VT going on right and left side.
Okay. So let's. So this is a VT because it's a broad complex angular tachycardia and it's VT. And if
Yeah.
you look at V1, you see a right bundle branch block morphology. So that means that your left ventricle is stimulated first. That means that the focus that is firing is in the left ventricle. Does this affect our treatment in ED? No, we will treat this as VT. This affects the electrophysiology team when they deal with these patients. But the reason for me to mention that is if it looks like a left bundle branch block morphology VT, like this example, that is one of the features that would suggest that you're dealing with an ARVC patient. And this is the VT of my patient with ARVC, because basically the left bundle branch block morphology means that the focus of fire is in the right ventricle, and you would expect a focus in the right ventricle with ARVC because the pathology is in the right ventricle. So those are the two ECGs that
Yeah. Can you just label this ECG the way the previous one was with the marker, just to get clarity on the V1 here?
Yeah, so looking at V1 with the marker, where is my marker? Here is the marker. So if you look at V1, this is V1, you will notice that we've got a small R, then a broad S wave that is going down. So the complex is pointing down, and that is what you see with left bundle branch block. And when you have this pattern in V1 in presence of VT, this suggests that the origin of this VT is coming from the right ventricle.
Excellent.
Okay. So, any difference in treatment in VT due to RVC? No, you would treat them exactly the same ANKIT. So treat them just like any VT. You would give, so according to the Rhesus Council UK guidelines and ERC guidelines, you will treat if they are stable with amiodarone, and you will treat if they're unstable with a DC cardioversion. And I would do exactly the same for this. So treat the VT just the way you would treat it.
What's the definition of stability in terms of blood pressure in objective numbers?
So that is a tricky question. So the Rhesus Council UK guidelines would define it as shock, so systolic below the 90. but syncope is a sign of instability. So I would include that there. Having cardiac sounding chest pain is a sign of instability because of a lack of perfusion to the coronaries. Change in the conscious level could be considered a sign of instability because of a lack of a perfusion to the brain, but that shouldn't last for long. That's a kind of a peri-arrest sign. And having signs of acute heart failure would be considered as a sign of instability as well. So to answer your question, a systolic of 90 is usually the number, but I don't like going with absolute numbers. I look at the patient as a whole.
So if the patient is looking stable to you with a blood pressure of say 96 systolic, and the VT has been going on for say around 2 hours, it's a real life case I'm sharing, and the only history is that there was some chest pain in the beginning, but not at the moment when the patient is in the ED with you, will you shock the patient? No other features of shock.
So I would, what I would personally do here, and that is of course a judgment call that you would make looking at the patient in front of you. I would I would be worried about my diagnosis. So VT that is running for 2 hours without causing any signs of decompensation in an old person, I'll be worried about that it might not be VT. But if I think it is VT and it's going on, and the only issue that I have is a systolic pressure of 90, I would prepare my sedation, but I will be giving amiodarone and I will prepare my pads on the patient and I will be ready to go for the shock if any further signs of decompensation, but I will consider amiodarone rather than DC shock as the first line of treatment. But that is a personal practice. And again, I will be thinking a lot before making that decision depending upon the situation. So
Yes, you are
usually
very,
happen
very
on the
right. Very right. And that patient has actually this, what do you call as a re-entrant phenomena, which was causing that kind of picture. And as you correctly said, a lot of thinking is needed whether actually it is a VT to begin with. But of course, if it compromises, then you have to treat it as a VT and shock them. But as long as not, then you have to kind of decide antiarrhythmics and ask for some more help of more intelligent people who can come and support you, or maybe not, or maybe they can put a complaint against you, which happened in real life because they thought why did they were called, when it turned into, later on the patient compromised after their arrival after some time, and then they said why the ED could not handle it. So that's the game of the, this thing. But of course they were found dumb when real facts were given to them in writing back. But yeah, that's a interesting thinking, and I'm glad that I'm thinking the way you have been thinking as well.
Well, uh, having said that, away from the politics around these things, my thought process is because I get that question all the time. Um, how can we differentiate ventricular tachycardia from SVT with aberrancy? That is a common question that I get, and my answer is always I don't think you need to differentiate the two. If it looks like VT, treat as VT, and most probably you will be okay, and that will be safer. And the reason for me to say it that way is there are so many different algorithms that you can use to differentiate the two from each other. So something like the Brugada algorithm, or there are so many different algorithms. To my knowledge, and correct me if I'm wrong, there isn't any that is 100% sensitive, 100% specific way to differentiate the two. And that means to me that the algorithm might say not VT and it is VT. And I don't want to miss any VTs. So that's my first reason behind I don't want to use the algorithm to differentiate the two because I'll end up missing VTs that way. My second reason for not applying these different algorithms is none of them, and again, correct me if I'm wrong, is easy to follow. All of them, you'll need to Google them, you'll need to find them on MedCalc and go through different calculations to do them. And in the heat of a moment, you are dealing with a patient who's got broad complex regular tachycardia, VT until proven otherwise. You're not going to be in a calm phase, relaxed phase. You're going to be in resus, in a stressful environment. And I don't really think that you will have the mental capacity to apply these different rules because they're not easy to apply.
Yeah, but
And my
if the blood pressure is okay, and it's a VT or a VT mimic or whatever it is, as you correctly said initially, and that was my first question, then you have to really think. But with add-on of this one on the top, but the blood pressure maintaining, then you have to be careful that whether you want to shock them chemically or you want to electrically. And that was what was the point I was trying to make. The blood pressure compromise, then yes, electronic, but otherwise consider and do chemical, and that's the politics around. Am I right?
Okay. And that will take me to my final comment about this. Let's say that you've used amiodarone for this as VT. It will help. It will fix it. Let's say that you were wrong and it was an SVT with aberrancy. Well, actually, amiodarone is one of the lines of treatment of SVT anyway. So using amiodarone here is going to fix the problem regardless whether it's VT or not. And to my little ED brain, anything that doesn't change the management plan doesn't exist. So as long as using amiodarone is going to fix my problem, whether it's VT or SVT with aberrancy, and it will not make me miss any VTs, I am sticking to this. And
Absolutely. No, no,
again, I'm
I'm
talking
fully
about
with
personal
you.
practice.
I'm fully with you on that. And the only reason I also brought this question because in one of the hospital's interview, I was given an ECG of a VT, and given the blood pressure was around 98 something, and I was asked, what will you do? And I knew it was a trick here, because whether you shock or not, because the VT, the impulse comes shock, because that's what I've seen happening in day-to-day practice, that majority of people see VT, forget to look at the blood pressure, and think more about it, which is better now, but definitely till few years back it was more of a practice, and still many places and people that they want to electronically shock. But that is something one has to give a little step, how, what is going on, is it a VT, and the blood pressure, is patient in shock, that's the point.
Yeah, excellent. Totally agree. So going back to your questions, I can see some questions here, so let me just go through them. Um, does it coexist with only left bundle, or it can present with right bundle branch block too? If the question is about VT in presence of ARVC, if the pathology is in the right ventricle, the VT will look like a left bundle branch block pattern. Obviously, any of us with normal both ventricles can have VT. So yeah, there is a chance that you might get a VT from the left side, but what's common is common. You've got a pathology, a fibrofatty change in the myocardium. You've got a focus in the right ventricle that is causing you troubles. The odds are, if there is a firing focus, it's going to be coming from this particular focus. So the VT will come from the right side, which means it will look like a left bundle branch block morphology VT. But there is no reason why. Never say never. There is a chance that it might happen from the right side. Next question from Crystal. The ECG example from Life in the Fast Lane, T-wave inversion in the limb leads. I'm assuming 2 and 3 are those important. Let's go to that. I'm just going to share my screen again. Okay, so in this ECG, I like your question because to be honest, I saw the same, and I think what we're looking at here is we are looking at a Fontaine lead ECG, but I am not sure about this because they didn't mention that clearly in Life in the Fast Lane. I think we are looking at an epsilon wave in here. The T-wave inversion here, I am not aware or that the ARVC can cause ST elevation in the inferior leads. So I am not sure why this is happening here unless this is a Fontaine lead, and that would explain seeing those. Again, my understanding of the Fontaine leads is that they will augment only the epsilon wave, but they will not invert the T waves. So I think this T wave inversion, I would say I cannot explain it and I don't know the reason for it. And they didn't talk about it at all in Life in the Fast Lane. So I am not sure. So is it associated with drugs? I am not sure, Hirsch, what you're asking about here. What do you mean by associate with drugs? Explain about TF block, so trifascicular block. Oh, that is gonna take long to talk about it. So let's see if we'll have any time at the end. Let's focus on the ARVC questions. Um, ARVC with left bundle branch block pattern happen to present the patient with high clinical suspicion of ACS. Would that affect the treatment algorithm, especially if it becomes difficult to discrete? So it's hard to tell. And again, I would always say treat the patient rather than the ECG. Um, if you've got a patient who's presenting clinically with ARVC, with ACS, with a cardiac sounding chest pain, then it is ACS that is causing the problems until proven otherwise. And by the way, myocardial ischemia, as far as I remember, is one of the causes of epsilon wave. So epsilon wave doesn't happen only with ARVC. There are other causes of of epsilon wave. One of them could be myocardial ischemia. So if you're dealing with ACS, if your clinical suspicion is high for ACS, whatever you find in the ECG will be going with ACS. If your presentation is syncope only and the patient is completely back to normal, then probably the ACS finding that you will find are not going to be because of ACS and they might be coming from an underlying ARVC. That is a differential that you'll need to go through when you deal with an ECG like this. And there is always the beauty of having a look at an old ECG to compare so you can get more information. And there will be always the cases that we will be stuck with and we will need further help and further investigations. Those are the ones to admit. Next question is duration of the upstroke of the S wave longer than 55 seconds. Can you please show on an ECG? So none of the ECGs I've had here were showing this in a good way, to be honest. So that's why I have picked the one that showed this. So let me show you that here. So again, what I'm expecting to see here is I'm expecting that the R wave that will be followed by an S wave, and the S wave should go up like this. What happens with the RVC is there will be a small R wave, then a vertically going down S wave just as normal. Then the S wave on the way up will not go straight up. It will just deviate a little bit to the side to make it as if it's being pushed that way. So that will make it broader from the top, narrower at the tip. This is what happens here. So if you look at the S wave here, it looks okay from the bottom and you would feel that it should be going straight up, but actually it got deviated to the side. And this is one of the characteristic features of ARVC. But looking at the ECGs for the examples I've shown here, it wasn't really that obvious. So in this one, I'll be pretending if I say that I can see it clearly. And in this one, I don't think it is there. And in the life in the fast lane example, again, I think we've got here a right bundle branch block morphology. And I think that's the reason for making things like that. And by the way, that could be the reason for having the T-wave inversions here because of the right bundle branch block morphology. That can cause T-wave inversions generally. So that would be my answer to this one. So if RVC with left bundle pattern happened, yeah, we've covered that. Um, if VT follow the ALS algorithm, yes, follow the ACLS algorithm. Um, is there a way to differentiate from RVOT or does it not matter from the ED? So from the ED point of view, it doesn't matter. Good news, the RVOT VTs are usually easier to manage and they respond well to antiarrhythmics. But generally speaking, from the ED side of things, it can help from the diagnostic point of view. So when you have a patient that presents to you with this ECG, just like my case. The presenting ECG is VT that looks like left bundle, and then you cardiovert them, or they become spontaneously cardioverted. I'll be very meticulous about ruling out ARVC in the baseline ECG because the presenting VT was with a left bundle branch block morphology. So I guess these were all the questions you asked. Any more questions?
Yeah, I've got a quick one, Hesham.
Yeah, sure.
So in the patient that we had as our example, just say we had that same patient and it was a new ARVD. So they were in VT, they're no longer in VT, they're now stable, they haven't required any resus stuff. They've self-cardioverted. Obviously, we're going to talk to cardiology about these patients. Should we be insisting cardiology come and see this patient in ED today? Or are they justified in saying, send them home, they're fine now, come back in a week to a cardiology clinic?
So, when it comes to the further management from the ED side of things, I think the example you're describing is basically a patient who presented to ED with VT. So let's stick to that. There is no VT patient that will present to you that cardio will say send home. So for those confirmed ARVC, or those with highly suspicion of ARVC or confirmed VT as the initial presentation, then there is a suspicion about the ECG. Those ones will automatically come into CCU for a monitored bed. And in the two cases that I've seen in my life, in both occasions, I would advise by cardiology to start amiodarone in between attacks as a prophylactic drug. So for both conditions, for both cases, amiodarone was started. If we're talking about an undifferentiated syncope presentation and the patient presented to you with syncope, now back to normal, there is no diagnosis yet, there is no ECG for the syncopal event, so you don't know really what happened there, but you've got an ECG that is showing or, suspecting, you're suspecting ARVC looking at the ECG. Those are the ones that I'm going to ring cardiology, and I suspect because according to San Francisco syncope rule, that's an abnormal ECG in the context of syncope. The risk for the syncope would have been because of a VT. For those ones, the usual advice is admit under medics. We will see there, and we will take it from there after ruling out all other causes of syncope. So I suspect if I'm in this situation, I will not discharge because per San Francisco syncope rule, those are unsafe to be discharged because they've got an abnormal ECG and there is a risk of going home, coming back in a VT. I will admit for a monitored bed to be investigated as an inpatient with cardiac MRI. That would be what I'll be pushing towards. And then I'll see how it goes with cardiology with that.
Yeah, fine. Well, that makes sense. Thank you. And what about if they've come in with something that's non-syncopal? They've come in with something irrelevant to their heart, and we found a query ARVD on their ECG.
Then it's a separate discussion. I will discuss with cardiology
Yeah,
regarding an outpatient follow-up, but I'll be very meticulous about my history taking here. So let's remove the ARVC out of the equation. Let's say that you've had a patient who presented to you with a let's say a dislocated shoulder, and you've tried without sedation and you couldn't do it. You decided to sedate, and as a pre-sedation preparation, you've done an ECG that showed a trifascicular block. What do you do with those patients? What I do with those patients is I take the history very carefully and I ensure 100% that there is no suspicion of palpitations, syncope, pre-syncope, and I make sure that what I found in this ECG is just an accidental finding that could have been there for years. And I send them home to the GP with a note that I've noticed this in the ECG for your kind care. If they faint, then that might be the reason. When it comes to ARVC, my slight change in my plan will be I will discuss with cardiology on the spot regarding an outpatient follow-up for the accidentally found Brugada syndrome in the ECG or ARVC in the ECG or HOOCM with no clinical manifestations as an accidental finding.
yeah, that makes sense. Thank you very much.
Thank you. Any more questions? We still have 5 minutes if you want to.
Regarding syncope, do you also follow NICE TLOC guidelines?
Yes. Do you have any specific point about the NICE that you want to ask about? Because I've got a feeling that there is a lot behind that question.
The thing is like, what I do in my practice, I follow it very thoroughly, or now especially tell juniors to go through it because of the supervisory position I do, and make them go through it very rigorously. And if I'm fully satisfied they've done everything and patient and it's looking all good, and of course cast an eyeball to go home, because I take syncope or pre-syncope something very serious. But even if I have got a minimum kind of height of doubt, refer to medics. And I've always seen that they, even though they argue, send them home, but when they come down to see them, because the patient is stuck because of the corridor of care we provide, no exit blocks, and then they 99.99% end up admitting them.
Fine. So here's what I personally do when it comes to syncope patients in ED, because that's a common important presentation to ED. I apply the San Francisco syncope rule. So I go through all the questions of San Francisco syncope. One of them is ECG. So the ECG is what we've talked about today. So I go through all of these. And then I check lying standing BP. I listen to the heart for aortic stenosis murmur, because if you faint because of aortic stenosis, that's an indication for valve replacement. So that's an admission. And I try to dig a lot in the history regarding how it happened and what was the exact position of the patient when it happened. Any faint without a prodrome, with while sitting or lying down, in my head is cardiac until proven otherwise. You're not allowed to faint while you're sitting. You're not allowed to faint if you're lying flat unless it's coming from your heart. In my head, there is no vasovagal that can happen in that position unless you've got a good story for vasovagal. And again, if you're awake and then syncope, no prodrome, that is your heart until proven otherwise. If that's all a no, then fine, let's talk about going home.
Thank you. You further simplified it. Great. What was the last thing you said? One thing you said was they are lying, and if they are sitting, it has to be heart unless proven otherwise. And what was the second thing you said? I couldn't get that one.
Fully awake, then syncope, no prodrome. That
Fully
is,
awake, no prodrome, then also, and syncope again. That is heart
yeah.
until proven. Yeah, that's I like the rules. That's a new learning in a very simplified manner. I like it. Thank you.
Thank you. I just like making things simple to me to apply it. Otherwise, I will forget them. So I just
Yeah.
have some simple rules in my head so I can run an ED.
Yeah, no wonder you are a hero. Thank
Oh,
you.
thank you.
Mine too.
Thank you so much. Any more questions, guys? Okay, so far it looks like everyone is happy. Okay, fine. So that will be it then for this one. Uh so my plan is I hope that this is recorded. I think so. And I will try to make that recording professionally edited, and I will make it available so you can have a an access to the recording. If you need a certificate for this session, I when I get the recording done, I will put it on my website so you can have it, do it again, and get a certificate at the end of it. So you can have it for your portfolio if you want to. And just to let you know, just heads up, I am running a one-day course on advanced ECG interpretation on the 16th of December. So again, be my guest. You are more than welcome to join. I will send you some information about this. And I have got some other free learning opportunities and courses that are recorded on my website that I'm going to send you links to as well if you want to have a look. And I guess I've talked too much. So thank you so much for
And
being here today.
can I give you a suggestive compliment?
Oh, thank you. Go ahead.
I think the way you simplify the things, you may perhaps consider approaching the EDI committee of Royal College of Emergency Medicine, who may be able to utilize the way you simplify things, and kind of make a collection of it, which you can provide them in a way that can be utilized for the neurodiverse trainees. And that may be very helpful because of the kind of requirement that will fulfill in a, of course it will be helpful for everyone, but especially further for that one. That's how I felt about it.
Thank you so much for this. I can't thank you enough for this compliment. And uh, yeah, definitely something that I can consider.
Yeah, and feel free to connect with me because I think I know the email or the names of the people. I can give you later.
Thank you so much.
Yes.
Great. Thank you, guys. I'm not gonna stop you from going for your lunch. So it's lunchtime now. Enjoy it, and hopefully we'll have more of these if you enjoy that. Thank you, and have a great day.
Thank you, Hasham. Have a great day. Bye.
Good to see you, Patrick. Thank you.
Thank you, Dr. Hisham.
Thank you.
Thank you, Dr. Hisham. Thank you.
Pleasure.